welcome to the February 2025 NASGP webinar. I'm here today with Claire Coughlan, who is the clinical lead for Bowel Cancer UK, and we're going to be talking about what GPs need to know about bowel cancer diagnosis and management in primary care. This is our second webinar this year. We've got another one coming up on the first Thursday in March, and if you go to our website you can read all about that. But for now, over to you, Claire.
Thank you very much. Good afternoon, everybody. I hope you're somewhere relaxing to listen to this talk, and I'm absolutely delighted to be here with you this afternoon. I'm just going to share my screen so that you can see my slides. Hopefully, you can now see that. As Ellie said, I'm the clinical lead for Bowel Cancer UK, and I'm also a nurse consultant at Lewisham and Greenwich NHS Trust in colorectal cancer. Thank you for inviting me to deliver this talk. The aim of the session this afternoon is to give an overview of bowel cancer. I'm going to talk about the current state of play and the red flag symptoms. I'm going to talk about the all-important use of qFIT for symptomatic patients, and then I'm going to talk a little bit about bowel cancer screening. I'm going to give an overview of the importance of genomics in bowel cancer and of Lynch Syndrome, a hereditary condition that predisposes to a higher risk of bowel cancer. And then I'm going to say a bit about the diagnostic and treatment pathways, and then about cancer care review that happens in primary care. So just to start with, if you could just scan the QR code, and that will take you to a quiz, so you can see, it will just tell me how confident you are in managing the symptoms, patients with suspected colorectal cancer symptoms at the moment. So if you scan the QR code that you see there, it should take you to a quiz, and then it should come up and tell me if you're confident or not confident at all. So 1 is not confident at all, and 10 is very confident. So I'm hoping that should just appear. It doesn't seem to be. I can't see anybody giving their views. It doesn't seem to be coming up, but hopefully by the time I've finished this session, you will be feeling more confident than you were at the start. Don't know why that hasn't worked, because it's been working absolutely fine, but we've got some more as we go through, and hopefully they will work then. So just to give an overview of bowel cancer, the current state of play. Every time I read these statistics, they still shock me. So we have large numbers of people are diagnosed every year with bowel cancer. And unfortunately, 16,800 people approximately each year die from bowel cancer in the UK. And the problem is that the majority of people are still diagnosed at a later stage, stage 3 or 4, and we know that survival is directly related to staging. So it's really important that people watch sessions like today, and we really work together to try and recognise the symptoms of bowel cancer and act soon when we see them. One of the biggest problems is that people that don't know the symptoms of bowel cancer themselves. And we did a recent study at Bowel Cancer UK that showed that 31% of adults in the UK couldn't name any symptoms of bowel cancer at all, which is a real issue. So that if you don't know what the symptoms are, how can you go along to primary care and see you and say that you're concerned? So for us at Bowel Cancer UK, it's really important that we monitor that, and we do lots of work to try and raise awareness of symptoms of bowel cancer. We know that about 54% of cases of bowel cancer in the UK are preventable. So if we got this messaging out there, then we'd be looking at far lower numbers than we are now. So we know that eating too little fibre contributes to it, eating processed meat, and something called a sedentary lifestyle that I always think sounds really nice, but just not doing enough exercise and obesity contribute towards bowel cancer. The cases of bowel cancer and increase your risk of developing bowel cancer. We've been asked questions recently about ultra-processed foods and whether or not that they are contributing to an increase in cases of bowel cancer. And the truth is that at the moment, the evidence isn't there. You see a lot in the press, and you probably have patients coming in asking you about it. But the truth of the matter is that we haven't got the evidence yet to say that ultra processed food definitely is a cause of bowel cancer. There was a meta-analysis of 45 studies undertaken recently that showed that most of the studies included offered very low quality evidence, and it doesn't consider specific confounding factors. So it doesn't take into account that people who eat lots of ultra processed food are far less likely to have lots of fruit and vegetables in their diet, for example. So it's difficult to tell what is the cause and to draw any conclusive evidence currently about ultra processed food. It's certainly one to watch, but I would say that when we're seeing people in primary and secondary care, the thing to say still is please try and eat more fresh fruit and vegetables and take a little bit of exercise and avoid those really processed meats. There are some groups that are at an increased risk from bowel cancer for a genetically determined reason. So those with a family history of bowel cancer, a personal history of bowel cancer. So if you've had colorectal cancer in the past, you're more likely to get it again than if you've never had it. Those with colorectal polyps, and other diseases, for example, inflammatory bowel disease, acromegaly. So there are other diseases that lead to an increased risk. We have some non-polyposis hereditary symptoms, Lynch syndrome, and that's the one that I'm going to talk about a little bit later. And also some polyposis syndromes, FAP, which is really interesting. If you have 5 minutes to look that up, you get a carpet of polyps over the colon, and a very high risk of colorectal cancer with that syndrome. And there are also some non-polyp syndromes that lead to bowel cancer. As I said, survival is directly related to staging, and it's really, really important that we emphasise this. So survival has more than doubled actually in the last 40 years for bowel cancer, and that's brilliant, and that's for a few reasons. One is an increase in the number of treatments available, so oncological treatments have improved, and the other is the bowel cancer screening program that I'll talk about a little bit towards the end of this talk. But still, survival is directly related to staging. So if you are diagnosed with bowel cancer at stage 1, so the very earliest stage, you have a 9 in 10 chance of being alive and well 5 years after your diagnosis. If you flip that to stage 4, that chance is only 1 in 10. And the reason I say alive and well is that the later the stage you're diagnosed, the more treatment you're likely to need. So those treatments all have effects, short and long-term effects. So even if people survive their bowel cancer, if diagnosed at a later stage, it is more likely to have a tremendous impact on their life and their quality of life if they're diagnosed at a later stage. The etiology of bowel cancer, I'm not going to dwell on the science too much, but I think it's just important to say bowel cancer does give us a fighting chance. So if you look at pathway A, that's your bog standard adenoma to carcinoma sequence. So it starts with an early adenoma, so an early polyp that develops into a later stage polyp that may give you symptoms, may give you some bleeding, and then eventually into a cancer that will, at the beginning, be a cancer in a polyp before it becomes a more invasive problem. So it gives us a really good chance to actually get in there and remove those polyps if we just pick them up early enough. The other two pathways, they're a bit more difficult. So pathway B, with the microsatellite instability there, that's the Lynch syndrome pathway. And you can see that's an accelerated adenoma carcinoma sequence. So it misses that lovely late adenoma stage that gives us a chance to catch it. And the same with the serrated polyposis pathways. Now, there's another quiz. I don't know if you can do it, but if you can, please do. And this quiz is just to ask you which of the following symptoms could indicate bowel cancer. So there's a list of symptoms there, and I just want you to click on the ones that you think are possibly a result of could be a symptom of bowel cancer. I'll just give it another few seconds, and then I shall go on to see. I don't know if anybody's scanning it. It doesn't seem there aren't. I can't see. I'm going to go through what the symptoms are now, but just to say, if you are watching this on demand, whatever you would call it, if we do see persistent anal anal itching, that isn't a symptom of bowel cancer, but I would still be concerned about it because it can be a symptom of anal cancer. So always consider what you're going to do with someone who tells you that they've got persistent anal itching, and examine their bottom, please, do a digital rectal examination. Blood in your urine, you obviously need a different sort of a doctor. You don't need colorectal, you need urology. And recurrent heartburn, well, that's an upper GI issue, not a colorectal. So they are still symptoms that may need some action. Frequent hemorrhoids are not linked to an increased risk of bowel cancer. They're really annoying, and you need to talk to your patients about eating more food, fruit and vegetables and fibre, and leaning forward on the toilet and adopting a squatting position when they open their bowels, but they do not lead to bowel cancer. So these are the symptoms of bowel cancer. So rectal bleeding, and that can be fresh, but particularly mixed with the stool, mixed up with the poo. Change in bowel habit. So if someone tells you that they've been to Magaluf and everything's now different, but if somebody's had a change in bowel habit for a good few weeks, and they don't know what's causing it. Abdominal pain, I always really, really stress this because quite a lot of the patients that I know that have been diagnosed through my practice and through the charity with bowel cancer have had abdominal pain, and they've tried to talk to somebody about their abdominal pain and they've been dismissed. Abdominal pain is not, I know you know this, you're all doctors, but abdominal pain is not normal. It means there is something wrong. It might not be bowel cancer, but it does need to be investigated. And all too often I hear people saying that they presented with abdominal pain and it was really difficult for them to be referred. Weight loss, an abdominal mass, iron deficiency, anemia. The difficult thing about bowel cancer is no symptoms at all, which is why that screening program is so important. Younger people get bowel cancer too. I always put this here because I think it's really important that we acknowledge that getting older is just a risk factor. So we know bowel cancer is still predominantly a disease of older people, but 2,600 people each year in this country are diagnosed under the age of 50. You can still get bowel cancer when you're young. So age is just a risk factor, like eating too much processed meat or red meat. So please just always consider that. The problem with these symptoms is that they're challenging because they have multiple differentials. There are lots of things that cause those symptoms: hemorrhoids, diverticular disease, and those conditions are really common. So when you've got lots of people coming to see you every day, as you do in primary care, or contacting you every day, it is not easy. I'm sure, I know from the referrals that we receive in secondary care, to work out who the people are that should be referred and who shouldn't. The real good news is the FIT test, the quantitative FIT test that you now have access to in primary care. It detects a breakdown product of human hemoglobin, and it is so much more sensitive than the old fecal occult blood tests that we used to have. We've got a lot more work to do with this, and we know that from the referral routes. We monitor this all the time, and we know that still nearly 20% of our patients come with a diagnosis of bowel cancer through A&E. There are multiple reasons for that, and actually we're thinking about doing more work looking into the reasons for that at the moment at the charity. It's multifactorial, but what we do know about this group of patients is that they are far more likely to present at a late stage, so stage 3 or 4 if they come through A&E, and we've seen the survival data. Still, it's about 10% of patients, I think it's just crept up to about 11 actually, are diagnosed through bowel cancer screening. And again, we know that if patients are diagnosed through bowel cancer screening, they're far more likely to be diagnosed at that early stage 1 or 2, and so have much less treatment and a much greater chance of surviving this disease. 55% are diagnosed coming through primary care. What's important about that is that what we need to do is get the right patients fast-tracked on the suspected cancer pathways, and that's the bit that's difficult. In the trust that I work in, I clinically lead the 2-week wait or urgent referral pathway service. We have about 600 referrals each month, and less than 5% of those referrals will be people with bowel cancer. This is really, really difficult. So the more we can do to get the right people down that pathway, the better. It's great for the people that have cancer excluded. They're told that very quickly, and that really reassures them. But we need to get people with bowel cancer down these correct referral routes. I just include this case study as I think it just illustrates the sort of better position we're in now that we have the FIT test. So this is a 35-year-old lady. She's a real person. Her symptoms began in 2018. She was feeling tired and run down, and she went to her GP. And she was kind of reassured. She was a very busy person. She had a young child and a full-time job. She chatted it through with her GP. She felt reassured, and off she went. 3 weeks later, she wasn't getting any better. And now she had like a stomach upset, what she kind of thought was a bug. And she'd had blood in her stools that she thought were hemorrhoids due to childbirth. She went again to see her GP, and unfortunately, she got sent home. She said her GP dismissed her concerns. I'm sure I can see how when she's presenting saying that she'd had this gastric upset and she had hemorrhoidal bleeding, and maybe even was examined and there were hemorrhoids present, this is not easy. Her bleeding continued, and she discussed it with a friend, and they talked about a young person that had been diagnosed with bowel cancer. So she then went back to see her GP, and at that point, actually, her GP did really well. She said she begged to be referred. She actually had bloods. She was found to be anemic, and she was then sent in on an urgent suspected cancer referral. Unfortunately for this lady, by then she had stage 3 bowel cancer. She needed surgery. She had a temporary stoma. She needed chemotherapy with all the side effects that come to that. She actually was found to have Lynch syndrome later on. The reason I include this case study is that FIT wasn't available at the time that this lady was diagnosed. We weren't using the FIT test widely in primary care. It hadn't yet been implemented. Had it been available at this time, when this lady first went to see her GP, or certainly on the second occasion, had she had a FIT test, her story might have been different. She may have been diagnosed at stage 2. She might not have needed a temporary stoma. She might not have needed chemotherapy. So I include this case study because just to say this is a really, really useful tool for us to help us pick these cancers up earlier and help people get an earlier diagnosis. So this is the evidence for FIT. This is the original study that everybody was focusing on when we first implemented FIT. So and it looks at the risk of bowel cancer in a 60-year-old with abdominal pain and a change in bowel habit. So what we know is that you have a 1 to 2.6% risk, if that is a description of you, of having bowel cancer. For a person with a positive FIT test, you have a greater than 10% chance of having bowel cancer. So it's an absolute no-brainer. NICE recommends an urgent referral when a risk of cancer is greater than 3%. So if you have a patient sitting in front of you and their FIT test is positive, fantastic, refer them. It's really, really helpful. In addition to that, however, it's really important to say that we must safety net patients. We're getting more and more evidence on FIT, and that's great. It will continue to emerge, and we will continue to include it in these talks. A systematic review was done recently. I'm sorry, because I thought the reference was on there. If you want it, get in touch with me. I'll give you the reference. But essentially, it looked at 26 primary care studies. What they found is that 1 in 10 patients that have a diagnosis of colorectal cancer will have a negative FIT. So for the whole population, all the people that don't have colorectal cancer included, it's a really, really good indicator. You have a very low chance of having colorectal cancer if you have a negative FIT. You can see it here, a 0.1 to 0.2% chance if you have a negative FIT, and that is for the whole population. But what this review found is that for 1 in 10 people with colorectal cancer, they will still have a negative FIT. So what that means is FIT is a fantastic tool. Anybody with sort of vague symptoms, you can undertake a FIT test if it is positive. Absolutely get them on that urgent referral pathway. If somebody has a negative FIT and they have real persistent symptoms, you need to consider safety netting them. So either repeating the FIT test or referring them to secondary care in any case. And I will say a bit more about that in a second. So what I would say about FIT is it's a really helpful tool, but it doesn't replace clinical acumen. So taking a really good history and knowing exactly what's going on with your patient. So if someone pitches up to you in your in your clinic, in your primary care practice, or if you're talking to them on the phone, you're going to talk to them first of all about their signs and symptoms. If they've got signs and symptoms of bowel cancer, please do a FIT test. Also do a full blood count. It's really important we know whether these patients are anemic, check their ferritin, and please, if you can check their renal function, that is so helpful for us in secondary care in determining what the right test to do is. If you're lucky enough to have them sitting in front of you, put your finger in their bottom, you might just find a rectal cancer. If they're not in front of you, I personally, it's great if you can examine them. If you can't, just do the good history in these tests and get them referred in. But if you can examine them, fantastic. If they have iron deficiency, anemia, weight loss, or diarrhea, please do a celiac profile. If they're unable to complete the FIT, please include the reason on the referral. The idea of the FIT test is not to accentuate inequalities and make things harder for people. We know that there are some people that will just never do a FIT test for a variety of reasons. They might not have the dexterity to do it. They may have some mental health problems, and that means that they're not well enough to do something like a FIT test. They might have all sorts of social problems that means that doing a FIT test never gets to the top of their priority list. That is fine. Please just explain it on the referral. And if they've got persistent symptoms, please still refer them. So if you have a patient with symptoms that has any of the following risk features, please refer them in. So they've got symptoms and a positive FIT, great. If they've got an anorectal mass or an ulcer, if you do get to examine their bottom and you see a mass there, please refer them. If you examine their abdomen and they have a mass, please refer them. And if they have, at the moment, the guidance says if they've got iron deficiency anemia or microcytic anemia, please refer them in. It's really helpful if you can also do a FIT test, but at the moment, the guidance says please refer them in with iron deficiency anemia. So please complete the urgent referral, including the FIT result, the digital rectal examination if you've got it, a clinical and family history, and fitness for investigation. Quite a lot of these patients now will be triaged straight to test. So they may have a telephone call from a specially trained nurse to take their history. And it really helps us to know what the right thing to do is first time, if there's good clinical information on the referral. So it helps move patients through the pathway and get investigations more quickly in the right way. If you haven't got a lot of information about somebody and you ring them up thinking they might be suitable for a colonoscopy, and then they tell you about their multiple comorbidities or their learning difficulty, or whatever it may be, and you then realise actually what they need is a face-to-face appointment to really determine their fitness and the best thing to do, it wastes time and it sort of clogs up the system. So the most information you can give us in secondary care, the better, please. Patients with lower GI symptoms who can't be managed suitably in general practice can be considered for referral to gastroenterology if you're not concerned by their red flag symptoms. If they haven't got red flag symptoms, if there is significant clinical concern, you can do 2 FIT tests a couple of months apart. If they're still then having symptoms, you know that they need to be investigated. So please do send them in. Sometimes you may think you don't want to wait that length of time. You don't want to wait the 2 months and do another FIT test. But if you do, that's great, because we know then that they really do need to be investigated. Occasionally, we'll have people referred into us with a negative FIT and some kind of vague symptoms. And actually, when you talk to them, they don't really want to have a colonoscopy. They can think of nothing worse, and they're not going to have it anyway unless they absolutely have to. And at that point, we will end up referring them back to you in primary care and asking you to repeat the FIT. So you can do that yourselves. If you've done it twice and they're still concerned, then send them in to us. But otherwise, you might find that they're sent back to you to do that. So, this next quiz, if you can do it, which I don't know that you can, is about bowel cancer screening. So it's a question about what is the current bowel cancer screening age in England? But it seems that nobody seems to be able to activate it. So I'm just going to tell you. I'll move on to the next slide. That's the correct answer. So no one participated. I don't know why. Okay, so bowel cancer screening is offered in England to people aged 50 to 74 to check for bowel cancer. Now, the really, really important thing about this is the abnormal threshold. When you request a FIT test in primary care, so when someone's sitting in front of you saying, oh, I've got these pains in my tummy and my poo's a bit different, and you send them for a symptomatic FIT from your practice, the abnormal cutoff is 10. So it is much, much lower than for bowel cancer screening. The bowel cancer screening program is excellent. We are finding more cancers earlier. We're finding adenomas and we're removing them. It's doing a great job, but it is set like this for the maximum benefit at the moment for the maximum number of people. So we've had age extension in England and Wales, and that's brilliant. And people are now having bowel cancer screening from the age of 50. That is great news. The cutoff in England is 120, the same as in Northern Ireland. Screening doesn't start in Northern Ireland until age 60. In Wales, they've brought their abnormal threshold down to 80. So we'll get some really good evidence from bowel cancer screening about what it means when the threshold is lower. So essentially, all that means is that in England, you need a bit more blood in your stool for it to be picked up than you do in Wales. So we'll find out a bit more. Scotland isn't on this slide, but I think that the age is 50 in Scotland as well. So that's our bowel cancer screening program. There are some areas where people don't participate in great numbers, and there's lots of work going on by the bowel cancer screening program themselves and by us at Bowel Cancer UK to try and encourage people to take up the opportunity to have a bowel cancer screening test. It is a great opportunity and genuinely saving lives. So please do encourage your patients to do their bowel cancer screening. But also please remember that if somebody comes to see you and says, but I've had a normal bowel cancer screening test, but it can't be that, it absolutely still could be that. And they need to have a symptomatic FIT test requested through your practice, please. Now, I'm just going to talk a little bit about genomics and bowel cancer and targeted therapies for a couple of reasons. The first one being that this is part of the reason that survival rates are improving. And I think it's really good for us to know that and to understand why that's happening. And the second one being that genomics are the reason that we're finding out about more people that may have an inherited condition that leads to bowel cancer. So we know that survival in colorectal cancer depends on how early or late you're diagnosed. 5 to 10% of all bowel cancers are caused by a known gene change. So they're hereditary, and we need to find out the people that carry that gene change. In addition to that, though, identifying DNA changes, so mutations that may contribute to cancer or control how a tumour develops, can offer potential new targets for drugs. So we already have personalised oncological medicine. We have immunotherapy. We have therapies that are targeted at certain types of tumour. So it's really important that we find out what these mutations are. And that means we can find therapeutic strategies that improve prognosis and survival. And that's already happening, and that's fantastic. The other thing about this is that we're looking for patients that may have Lynch syndrome. And we're doing that because it helps us to treat them, but it also helps us to find members of their family that might be affected. And then we can try and prevent bowel cancer. There's more information on that link, or you can go to our website, Bowel Cancer UK, and there's a lot more information about the picture for Lynch syndrome across the UK. In primary care, what it's important for you to do, please, is consider people's family history. So please remember the 3-2-1 rule. So if someone is sitting in front of you and they tell you that they've got 3 family members that are affected by bowel cancer or endometrial cancer across 2 generations, so their mum and their sister, or their mum and their granddad on their mum's side, and 1 family member was diagnosed at a young age before 50, so 3-2-1, that is potentially a Lynch syndrome family history. And if you pick somebody up with this family history, please refer to your local genetics service or to your local family history clinic. If you can't find that, send them to your colorectal team and they'll make sure the referral goes to the right place for you. So please just remember that rule: 3 family members, 2 generations, 1 under 50. And those patients need to be picked up so we can do the appropriate testing. What we're looking for is Lynch syndrome. It's an autosomal dominant condition, so you've got a 50-50 chance of inheriting it if one of your parents has got it. And this condition predisposes to certain types of cancer. What we know about Lynch syndrome is that we think there are about 175,000 people in the UK that have this syndrome, but we only know about 5% of them. So it's really important that we find out about these patients, about people that have Lynch syndrome. The reason it's important is that you have an 80% chance of getting bowel cancer if you have Lynch syndrome, 60% chance of endometrial cancer, and so on. So we really need to find out who has Lynch syndrome because we can help manage their cancer risk. There has recently been something called the National Lynch Syndrome Project. It's just finished. The aim of this project was very well funded by NHS England, and the aim was to improve access to Lynch syndrome diagnoses. So developing new skills in regional colorectal MDT teams, multidisciplinary teams, so that we have mainstream testing for Lynch syndrome. So what that means is when somebody is diagnosed with bowel cancer, they have the genomic testing that you need to have to see which oncological treatments may be best for you. But in addition to that, whether they need oncological treatment or not, they have MMR testing or MSI testing, essentially to see if their tumour might be the sort of tumour that it comes from having Lynch syndrome. If that is the case and the clues are there, they then go on and have mainstream testing for Lynch syndrome. And that is for everybody with a diagnosis of bowel cancer. The reason that's important is twofold. Firstly, if we find out who has Lynch syndrome, we can then test their relatives to see if they have it as well. So it's vital that we find out who has Lynch syndrome. It also gives the person themselves improved access to personalised oncological and surgical care. If we know that somebody has Lynch syndrome, we can manage their cancer risk. So remember that etiology slide that I showed you right at the beginning about the accelerated adenoma carcinoma pathway? For that reason, patients that are known to have Lynch syndrome need to have a colonoscopy every 2 years because the polyps grow more quickly than in the normal adenoma carcinoma pathway. So they need more frequent colonoscopies so we can remove the polyps. They have aspirin because it reduces the cancer risk by 50%. The evidence is compelling for patients with Lynch syndrome. It's not yet there in the general population, but it's compelling for those with Lynch syndrome. They can be offered a prophylactic total abdominal hysterectomy and bilateral salpingo-oophorectomy, and they can have adaptive surgery for colorectal cancer. So it's important that we find these people so that we can manage their cancer risk. It is possible to do. Now, whatever route your patients come into secondary care, whether you've seen them and you've put them through on an urgent referral, whether they've had a positive bowel cancer screening test, or whether they're known to have Lynch syndrome, they should end up having one of these fabulous things, a colonoscopy. So this is the best way to diagnose bowel cancer. You'll know what it is. It's a bendy tube with a camera and a light on the end we put in through your bowel. The thing on the left is a beautiful clean transverse colon. You know that because it's a triangle. The thing in the middle is a fantastic thing to see. It's a polyp, it's an adenoma. You can get a snare around that polyp and you can remove it. And the thing on the right is the thing that you don't want to see, which is a bowel cancer. And a colonoscopy is the way that we diagnose. If you think your patient may not be fit for a colonoscopy because it's invasive and requires bowel preparation, we do have alternatives. We have CT colonography, capsule endoscopy in some areas. So we can do these tests. They're less invasive. And if we find a bowel cancer or a large polyp, we can then have a conversation about fitness and what's right for each patient. So do please still refer them, even if you think they might not be fit for a colonoscopy. Once we find the cancer, we do staging. So that's the staging there, 1, 2, 3, 4. We use CT scans, MRIs, a PET scan, and there's a multidisciplinary team discussion for us to determine the best treatment. The treatment options are more wide and varied than ever before. For early cancers, they can be removed endoscopically. We can have brachytherapy, surgery that can be done the keyhole, robotic surgery way, or open surgery, radiotherapy, sometimes as a sole treatment, but more commonly before surgery for rectal cancer. Chemotherapy, sometimes it's given in an adjuvant setting, a neoadjuvant setting to downstage, make a tumour small enough for an operation, but more commonly it's given after surgery. and those biological therapies and targeted therapies. So a whole range of treatments available for people once they have a diagnosis of bowel cancer. We know that having had treatment for bowel cancer has many effects, and this is just a list of them. So this is from data that you get from Macmillan, from the holistic needs assessments that are undertaken in secondary care, and also from the National Cancer Patient Experience Survey, and also from our forums at Bowel Cancer UK. So people tell us they're worried their cancer will come back, they're worried about their future. People tell us they don't know where to get information, which is why we try really hard at Bowel Cancer UK to provide that. People tell us they're tired, they get into this cycle where they can't sleep properly, they have pain, it prevents them sleeping, they can't exercise, they're worried, and that prevents their sleeping, that they get into this cycle that we can really help to manage if we know about it. Changing bowel habit is a really common one, and again, there are things we can do to help with that. Tingling in hands and feet, so peripheral neuropathy. It's really common after a chemotherapy called oxaliplatin that we use in bowel cancer, and it can be quite debilitating. And people tell us they worry about their job, their education, and they still, of course, have their pre-existing comorbidities. So in primary care, you're charged, as I know you'll be aware, with undertaking cancer care reviews within 3 months after a patient's diagnosis, and after they've finished their acute treatment, and within 12 months. It's a quality indicator, and it's really, really helpful if you can work with secondary care and undertake these cancer care reviews. Now, in your individual areas, they may have some prompts. This is one that I did with South East London. And it's literally, I'm not going to talk through these slides, they're far too busy, but I have them here just so you can see that resources such as this are available. They should be available in your area. If they're not, and you want to contact us at Bowel Cancer UK, I'm very happy to share the resources that we've developed, and they just give you prompts to talk through what the effects might be with your patients, and give you an idea of how you might be able to manage and signpost patients that are experiencing effects of treatment for colorectal cancer. So the final thing would be a Slido, but I don't think it works, so I'm just going to skip over it. But hopefully, having listened to me for a little while, you're more confident now in managing suspected colorectal cancer patients. Please keep those red flag symptoms in your mind. Always undertake a FIT test, and if you're still concerned, safety net your patients, and if they are really persistent symptoms, please do refer them into secondary care. So all I want to do now is just take a minute to just say to you, we've got lots of support for your patients and education for you on our Bowel Cancer UK website. We have an Ask the Nurse service. It's staffed by 3 fantastic colorectal nurse specialists who have a wealth of information. They also have access to our medical advisory board, who are oncologists and surgeons who specialise in colorectal cancer. So they get lots of information for patients, but are also quite often used by GPs or nurses. So feel free to use that service. It's a really well evaluated, good service. We have a newly diagnosed support book that are out there now in secondary care. They've got great diagrams on them. You as health professionals can order these if you would like them, but they're more commonly used by colorectal nurse specialists. We have great online communities. Tell your patients about these, please, because they're so helpful. They're moderated and they're on all sorts of topics for people that are newly diagnosed, people with advanced cancer, people with a stoma concerned, for carers and loved ones. And there are also Facebook groups, and you can see the topics there and just have a look at our online communities. We have a peer support line. That's a new service. We've got trained volunteers. So if somebody's been diagnosed with bowel cancer and they just want to talk to somebody, they can ring up and speak to somebody with lived experience. The other thing about this service is if it's obvious that actually what they need is a conversation with a nurse, whilst we haven't got a nurse helpline, we have the email service, but the nurses will ring patients back if they're signposted to by the peer support line. So that's a really great service. We've got a wealth of health information that you can look at on our website. And for you in primary care, we have online learning modules. So please do take a look at those. There's one about early diagnosis and optimal management, use of FIT, another one about the bowel cancer screening program. We did a special module for colorectal cancer in younger people, telling you about the issues faced specifically by people, younger people affected by bowel cancer. One about Lynch syndrome. If you found that sort of mention of it today interesting, please do go ahead and do the module, and more about FIT and early diagnosis. So thank you very much for listening to me today. If you've got any questions, you are welcome to ask them now, although I don't think we've got that much time left. I'm looking at Ellie. But you're also welcome to send them in to us at Bowel Cancer UK if you would like to.
Claire, thank you so much. That was a fantastic presentation, packed full of information, and great that if GPs want to know more, they can go to your website to the is it the How Can We Help section, or How Can I Help?
Yes, I think Beth was going to put it in the professionals website, but yeah, go on to the How You Can Help How You Can Help section, and you'll be able to get in touch with us. And the Ask the Nurse email address is on there as well, and that's really, really useful resource.
That's brilliant. All right, well, thank you for your help, and we look forward to sharing any feedback we get on the video with you soon.
You're welcome. Thank you.